Hi, I'm Jennifer Kalish, a clinical geneticist at Children's Hospital of Philadelphia, and today I'd like to talk to you about expanding the phenotype of WAGR syndrome to a spectrum. So when we think about WAGR, we're talking about a rare disorder caused by deletions on chromosome 11p13, where the phenotype was classically defined as Wilms tumor development, aniridia, genital urinary abnormalities, and a range of developmental delays. There does seem to be, in some cases, increased risk for obesity and renal failure as well. The purpose of this study was to really do a comprehensive investigation of the full clinical spectrum to update from the previous evaluation of this population, which was over 15 years ago. So classically, the W stood for Wilms tumor development. In the spectrum criteria, we're going to expand that to include nephrogenic breast development as well. Classically, the A is for aniridia, but in the spectrum, we're including other eye or ocular issues as well, beyond aniridia. The genital urinary malformations need to also include genital and nephrourologic abnormalities, so a little bit broader. And then the range of developmental and learning issues has been expanded to include mild delays as well. For this study, data collection occurred through a registry set up by the International WAGR Syndrome Association. And for this, patients completed a specific questionnaire, and the questionnaire covered a range of clinical presentations and features. This was managed through an online disease registry platform set up for rare diseases. And this was used to create the WAGR discovery cohort, which is all of the data I'm presenting today is from that cohort. And that included basically analyzing the data and doing descriptive statistics within the database. All data points were summarized based on frequencies, and the number of participants for a certain issue were compared to the total number of participants. This population included 91 unique individuals, 52 females, 37 males, and all participants, or almost all participants, indicated that the source of their diagnosis was genetic testing in a laboratory. Participants either were enrolled and surveys were completed either by a parent of a child who was under 18 or a legally authorized representative if the participant was an adult. These were all self-reported medical history and health issues and were collected between 2014 and 2020. The clinical issues reported by the discovery cohort included the classic WAGR features, but in addition, there was a number of non-classical clinical issues that were reported. There was more details on obesity and heart disease and chronic kidney disease as being more common than initially thought. In addition, about a third of the cohort reported congenital anomalies of the kidney or urinary tract. You can see the range of issues reported here. There was a number of cardiac metabolic health issues that we'll get back to a little bit later, kidney health issues, and the overall review of systems included a number of things that were not classically characterized or thought about as part of WAGR syndrome, including respiratory issues, musculoskeletal issues, GI issues, sleep issues, allergy, dental, neurologic, and hearing loss were the top things reported. So in thinking about this, we decided we needed to reconceptualize WAGR as a spectrum disorder, realizing that not everyone would be captured under the current syndromic definition. The spectrum really emphasized the range of possible conditions and severity, with the idea being to assist physicians and care providers in recognition, diagnosis, and treatment of the spectrum. This could lead to more specific research within a specific condition within the spectrum and expand the phenotype to increase the diagnosis for the non-traditional presentation of these patients. So this is a comparison looking at patients in this cohort if we use the syndrome criteria or use the spectrum criteria. And as you can see across all of the different criteria, if we expand to a spectrum, more patients would be included within the population, and we would be able to basically broaden who would be included and who would potentially be diagnosed. So now that we have this concept of a spectrum, what's the comprehensive way to approach, work up, diagnose, and care for these patients? So to establish the correct diagnosis, it's important both to have professionals and specialists who are familiar with the syndrome and to establish both baseline health concerns and immediate care needs. The diagnostic workup initially should be guided by a specialty genetics team, and that can be expanded out depending on the medical needs of the patient. For patients without a molecular confirmation, but still have a phenotype that falls in the spectrum, can receive a clinical diagnosis. In terms of providing baseline health assessment of these patients, we want to basically include imaging and other ways to diagnose internal GU anomalies or abnormalities so that they can be both diagnosed initially and also managed over time, because the goal of all of this is both not just the diagnosis initially, but long-term health for these patients. The core specialists should include pediatricians, geneticists, ophthalmologists, nephrology, urology, and oncology, or cancer predisposition, depending on the needs of the patients, and secondary specialists, depending on the specific patients, and the personalized medicine approach for these patients could include cardiology, endocrinology, neurology, pulmonology, or others, really depending on the specific needs. In order to both care for patients beyond the initial diagnostic period, it's important to basically develop medical homes and specialist care teams. This is a matter of coordination between the patient and family and the primary clinical home, the pediatrician, and a specialty home, whether that's the genetics team or other care teams to manage health issues. As part of this, we recommend creating an individualized care plan and to initiate the WAGR Spectrum Screening Program, which I'll talk about a little bit more later, but to determine what other care specialists are needed and the follow-up schedule for both monitoring and treatment based on the core specialist and referral team. And each of these core referrals and specialists is dependent by the patient's unique needs. In addition, referral to the psychosocial and developmental support services is really important. It's important to consider both the developmental support services to manage the range of features, whether it's behavioral, emotional, or cognitive, and to provide information for parental support through the International WAGR Syndrome Association as well. The goal is overall care management is really to improve long-term outcomes. So there's early detection and treatment that can help mitigate the long-term organ damage and adverse health consequences. This includes strategies to basically have routine health profile assessments and to basically determine what screening program follow-up schedule is needed. Prompt referral for a specialist is really important if an issue is determined or if there's progression of issues. These include specifically kidney health, looking at kidney function to basically prevent damage, monitor and screening for urinary tract infections, for tumor growth and kidney disease overall, for cardiac and metabolic health to manage weight, to prevent obesity, to monitor and screen for urinary tract infections, tumor growth, kidney disease, etc. Eye health is very important, both using artificial tears as needed to avoid contact removal unless the functional vision is blocked, and to basically continue to monitor health and eye health. Hearing screening is also important as part of routine evaluations and to improve quality of life. For urinary and kidney issues, it's really important that we basically determine that if these are present or not. More than half of the children or adults in this discovery cohort were affected. The most common issues were ambiguous genitalia, delayed bladder emptying, recurrent UTIs, and then congenital anomalies of the kidney and urinary tract. There does appear to be a causative correlation between the recurrent UTIs and the congenital anomalies of the urinary and kidney tract. So it's really important to have these monitored over time. For screening and kidney health screening, renal ultrasounds are recommended every 3 months until the 8th birthday, focusing more on tumor risk early on, and then every 6 months from 8 to 18 years, and then annually after 18 years. However, if there's urinary or renal malformations, this frequency may vary, and they may need to be more frequent to follow whatever the alterations are. Specifically for males and females, there are GU anomalies that need to be considered as well. We looked at the male population versus the female population in this cohort and saw that there was actually increased congenital anomalies of the urinary and renal tract in males and GU anomalies compared to females. The specific anomalies were male or female specific. And it's really interesting to see these two groups and to keep in mind that there may be different subspecialists that need to be involved depending on which population, if you're dealing with a male or a female here. Overall, it's really important as we try and think about wellness over the course, both from diagnosis and evaluation over the course of the lifespan, to really think about personalized medicine here and bring in the appropriate teams to promote wellness across the spectrum. That includes the primary care team, the specialty home teams, the specialist teams, and researchers to really improve how we care for patients both now and in the future. And of course, all of this is in partnership with patients and families and advocacy groups such as the International WAGR Syndrome Association. So the key findings were really that we have a spectrum, not a syndrome, and the spectrum is really a better representation of this patient population compared to the historic syndrome classification. Patients should be considered for an increased risk for obesity and chronic kidney disease, in addition to Wilms tumor, and internal genital urinary malformations and congenital anomalies of the kidney need to be considered, as they are often underappreciated in previous cohorts. And this study really highlights how important it is to partner with families to collect data, both patient-reported data and other information, to characterize rare disease populations such as WAGR, and the power of patient engagement in research. Future directions for this work are prospective studies to try and understand more about genotype-phenotype correlation, which I'm happy to talk about further if anyone is interested in contacting me. And I'd like to acknowledge the support both for this research of the Discovery cohort through Alex's Lemonade Stand Foundation and Miranda's Mission, the work with the CORDS Rare Disease Registry, which is funded by Sanford Health, and I'd most like to thank the patients and their families and the International WAGR Syndrome Association for their support, and the participants for sharing their experiences with us through this patient registry. And we look forward to continuing this collaboration. Thank you for your time.